Well, thank you very much, and thank you for inviting us, the representatives of Stoke-on-Trent, the only part of the UK that probably doesn't want to leave the European Union. So we're going to talk about a clinic that we, Donald and I, put together. This is Donald McBride, Tony Ward. We put together as an arm of our spasticity clinic, which had been going for some time. And this was really, once we made a decision to discuss surgery, we then would thought about, when it came to having a joint ankle and foot clinic, that we would actually involve the surgical team, but us going to them rather than coming to us for time purposes more than anything. So we're going to do...
Yeah, we're doing a bit of a rap grime kind of concept this afternoon. So anyway, this was actually to tell you where Stoke-on-Trent is, because no one will know where Stoke-on-Trent is. So here's Manchester, here's Birmingham, Scotland, Wales, and Ireland is over here. I'd just like to point out that Scotland, Wales, and Ireland did not want to leave the European Union. And really, it shouldn't be called Brexit, it should be called Engexit, okay? Because it's an English phenomenon, so to speak. So that's actually where we all come from. But Stoke itself is actually quite a big centre now. We have a major trauma centre, which actually has a lot to do with Tony as well. So it's developed quite a lot. Okay, Tony.
Thank you. Yeah, we have a population of 500,000 within the city, but we serve a population of 2 million people for trauma rehabilitation and for spasticity management. So we established this clinic in 2001, as I said, as an arm of our spasticity clinic. And we'd had a lot of referrals to and from orthopedic surgery, which were rather ad hoc and not defined in any way and not processed in any way. Can you all understand me, first of all? Yeah? Okay, good. So we recognize the need for better communication, for involvement of both the rehabilitation team and the orthopedic team. And Donald and I put this together. We had a group of people, podiatrists, orthotists, occupational therapists, physiotherapists, nurses, and we all got together. Some of them were part of our spasticity team as well. So we meet on the fourth Monday of every month, and we established it from pooling of relevant patients, most of whom had had some spasticity, but not necessarily. So it wasn't a spasticity-only team.
I'm certainly sure you don't understand me because my Scottish is not very good with the English, but anyway. So the kind of patients that we were seeing initially formed this kind of group. Effectively, it was a two-way process, though, regarding referral, because Tony would bring me all these very complicated cases that I had to go and read the books about and actually start doing something to understand them. And thankfully, there are teams like yourself who obviously do. We saw quite a number of stroke brain injury patients, actually, and others with various conditions. And diabetes, as you will aware, is a very common condition now and is increasingly a problem with Charcot. And at the bottom, it says complex regional pain syndromes, but I think it was most of my surgical cock-ups, actually. But basically, the problems I had, or some of the problems I had, Tony was very good at resolving. So it was that kind of patient as well from that point of view. So I had a nice combination of patients. You may ask things about CMT, HSMN, that kind of thing. We saw some of those patients, but actually in the UK, there are very good centres that deal specifically with those conditions. And so it was something we would see and refer on, basically.
So what did we do? What interventions? One was really looking at it from an ICF point of view. There were some patients in whom we could improve their function by a joint rehabilitation orthopedic approach, and others in whom we were actually improving their impairments, particularly postural problems, correction of deformity to allow better wearing of clothes, splints, etc., relieving pain. But we also had a lot of patients in whom we were going to try to improve their function to allow a better base of support for their walking, and thereby allow the therapists and the rest of the rehabilitation team to manage their proximal musculature in order to improve their physical functioning and their walking. This was just, as I say, a lower limb clinic, and so we had a similar approach with the upper limb with another team in another clinic.
Okay, so the assessments were very much general. A lot of these things had already occurred. So all of the patients we saw had been through neurology in some form or other, and/or gait analysis. So this was a kind of like very much more orthopedic sort of side of things, and obviously rehabilitation. So we had standard clinical assessment, therapy, which had included in the clinic, orthotic trials. We had an orthotist in the clinic. That was more beneficial than a podiatrist. But then in the UK, there's a bit of a sort of fight between podiatrists and orthopedic surgeons about who does the surgery, and that's kind of gone across most places, including the States, of course, as well. So the imaging, SPECT scanning was something that came along at the end, actually, as much as anything. That's more of a thing for me in lots of ways, because sometimes isolating pain problems in these kind of patients is quite difficult. So actually, pain may be sometimes associated with spasticity, but actually sometimes it's associated with other joint problems. And SPECT scanning, to me, has absolutely revolutionized how you can localize that kind of problem. EMG and nerve conduction studies, well, again, they'd already been done in most patients because we had a very good neurology setup. A lot of the time, the problem is whether or not you're dealing with a progressive neurological lesion, because if you are dealing with that and you're going to surgically intervene, you really could run into trouble if you're not quite sure exactly how that is going to progress. So that's quite important with the neurology appointment. And obviously, the gait labs that we've mentioned were available. Oswestry was the principal one, but we also have one in our own department. The Robert Jones and Angus Hunt Memorial Hospital is quite a famous hospital for that. And as you say, it's already been done most of the time beforehand.
So these are the range of activities that we did undertake. Obviously, a lot of the patients would have had botulinum toxin before they even came to our clinic. We certainly would undertake nerve blockade as a routine before committing a patient to surgery in order to allow us really to have a clear idea of what we were trying to achieve. And as Don has said before, they would have had a posture and movement analysis in order to know which were the actual muscles that we should be dealing with. And again, from a surgical point of view, the various kind of orthopedic interventions, tendon and soft tissue balancing, osteotomies, and the like. We don't really have much experience in the UK and among our neurosurgeons of doing neurotomies and the like. So we really are going to learn, say, once we leave once we leave Europe, we will learn all about this in a much better way. We have spinal cord stimulation in our center, and we refer to the patients to our pain center for that, where is necessary.
Okay, so basically, we were meant to see up to 6 to 8 patients. I didn't change this because normally we saw about 15 patients, and we kind of were meant to see 6 to 8 patients. So actually, over the period of time, we saw 2,500 patients altogether, Tony, in that clinic. And they were all new patients in general terms. Obviously, we're following up some of the surgical interventions. Tony has a very good setup in his rehab unit for that. I mean, everyone's mentioned that so far about what they do. Some of the patients we've already mentioned were post-operative pain issues. You can't always get to the root of that. CRPS type 2 is the kind of diagnosis that is commonly there, but some of the time as a surgeon will say they've got CRPS 2 because he just wants them to go away to somebody else, but there we go. So diagnosing that issue is something. And of course, we had other kinds of patients. So there were patients that I didn't think would benefit from an operation that I took to Tony, which is sometimes the case of whether you think they may benefit, they may actually be appropriate for an operation. But I think we will all know patients where we'd be concerned about adding an operation to them originally.
So as Don said, it's very much a case of the rehabilitation team referring to orthopedics, orthopedic team referring into rehab, and then the follow-up of all those interventions that are very important. We did an audit of our activities in 2014, 2015. Primarily the improvements that we saw within active and passive functioning, and also in relieving pain. You'll be able to read some of the patients we saw there. Most of the patients were not actually operated on. Most were actually had that joint assessment. The patient was then given the opportunity to know how best to carry on. And if it meant an operation, we then would have our nursing staff very much involved in the education of that patient and very much also involved in the post-operative care. Because the operation itself is a one-off procedure in the overall life of that particular patient with their particular problem. So it is very much a view of looking at how you're going to affect a change in that patient's overall management. I haven't got any actual outcome data to deliver today, but on the other hand, we have informal feedback from the patients. And it's very much a service clinic rather than an academic clinic. And with that, I think we will just highlight Sunshine in the United Kingdom, which is there all the time, our 2 centres, and the wisdom of this particular clinic in the aisle that you can see.
I'll just say one thing before we finish, actually. Listening to everyone else speaking this afternoon, you're all still involved in what you're doing, and this clinic is now finished, basically. So we feel like we're a kind of retrospective, rectoactive sort of like group to some extent. But this was starting at a time in Europe when there really weren't that many, and I would say that these clinics are so much needed and will be so much more effective for the management of these difficult patients.
Thank you. Thank you.